I don't know if you can see my screen on the first slide.
Yes, we can see it.
Okay, thank you so much. So I will give an overview about last advances in MDS in the setting of transplantation. And here is my plan, quite simple: when and who transplant and how to transplant, especially how to optimize a transplantation. So to consider transplantation, the main question will be, sorry, I can't see my screen. The main question is when consider transplantation in MDS patient. And to think about that, we have to estimate what could be the life expectancy without transplantation, which is mainly influenced by the disease, but not only, also patient characteristics. And what is the life expectancy with transplantation, which is again influenced by the disease, but not only, as you know, that's also influenced by transplant procedures and post-transplant potential complication. And we should not forget that these patients are at higher risk of cardiovascular risk. So here that the expected survival outside the setting of transplantation, and I have taken this recent analysis published in almost 3,000 patients, and using to develop the IPSS molecular. So you can see that from this IPSS molecular, we have 6 groups of patients from the very low risk to the very high risk who have a median survival around 1 year. And it has also been validated with a European consortium cohort, showing again these 6 groups of patients. So just to say that MDS is a very heterogeneous disease. And when we try to compare the most often used score, which are the IPSS, revised IPSS and the IPSS molecular, we have 2 categories of very high risk patients with survival less than 18 months. And we have this intermediate risk patients who have median survival around 3 years. And for them, that's especially difficult to know when they can have an indication of transplantation. And I will go back to this later. We should not also forget that some lower risk or intermediate risk IPSS patients have actually a higher risk of mortality due to different reasons that can be a non-response to treatment, myelofibrosis, or life-threatening refractory cytopenia, for example. That's not included in the IPSS. And here, that's just to show, for instance, that patients who are not responding to erythropoietin stimulating agent have a much lower expected survival than patients who responded. So now we move to the outcome we can expect with transplantation with these 2 studies. On the left, and the cohort from the Italian group, and you can see that IPSS, the revised IPSS, is still prognostic in transplanted patients with survival from 20 to 70%. And on the right, that the same before, but in transplanted patients, you can see that IPSS molecular is still predictive with different groups of patients. And again, even if that's a selection of patients, the survival are heterogeneous. From the last EBMT Congress, we have also this experience from the Latin American registry showing again that the revised IPSS is still predictive in transplanted patients. And in this cohort, that's the very high-risk patients who have the worst outcome. So if we would like to predict the outcome after transplantation, as I said at the beginning, we have to take into account different parameters, and we have many scores to do that, but I will show more in details the EBMT score, taking into account the age, cytogenetics, the type of donor, Karnofsky score, CMV, blast, and platelet. And you can see that if you use this score, you can predict quite very well the survival in this patient with low, intermediate, and high and very high risk. And all these variables which are predictive are not related to the disease itself. So that's very important to estimate before transplantation what could be the outcome in this patient, especially in intermediate risk patients. So that's the same issue finally that for myelofibrosis, where Nicholas Kroger explained that in this category of intermediate risk, that's very important to take into account all other parameters. So we have 3 prospective trials based on the donor availability, meaning that if we have the intention to transplant the patient and the patient has a donor, we can compare the overall survival of patients with donor and without a donor. Unfortunately, or fortunately, I don't know, today we cannot do any more this kind of study because almost all the patients have a donor, which can be an haploidentical donor. But anyway, in this study, we can see that there is an advantage of with transplantation, so in with donor, in terms of overall survival or even free survival in higher risk patients. So these patients are intermediate to or high according to IPSS. All of them are older than 50 years. And in the German study in the middle, all patients receive 5-ASA at diagnosis, and only patients with a donor were transplanted. And you can see that there is an advantage for EFS, but not the first 18 months where the 2 curves are superimposable due to the delay to transplant first, and secondly to the non-relapse mortality after transplantation. So the benefits is observed after the second years. So there is an advantage of transplantation upfront for higher risk MDS patients, but is it true for all patients? The problem is that we also have very high risk patients, mainly due to genetic alteration. That's what are showing these curves here, with survival less than 10% in patients who have a monosomal karyotype, especially complex, and high risk karyotype with poor risk mutation. So, for instance, in this large CIBMTR study, we can see that the overall survival is only 20% in TP53 mutated patients. And when the patient have no TP53 patient, but they are younger than 40 years, we have to check if they have other high-risk features, which are here. If not, the survival is 82%. If yes, that's 49%. In patients older than 40 years, we have to check if they have a RAS pathway mutation. If yes, the survival is 30%. If no, if they have JAK2, that's not different. The survival is 28%. So we have 3 major mutations with poor prognostic here. Given overall survival after transplantation between 20 and 30%. So now we will see if we can do better in these very high-risk patients, and keeping in mind that the only transplanted patients can have a long-term survival. So even if the survival is only 30% or 20% after transplantation, that's still better than without transplantation. So one of the issue may be to reduce the failure to transplant. What does that mean? It means that in the prospective study I have just shown, 20 to 30% of the patient could not reach the transplantation, mainly due to disease progression, but not only. And so that's also published on the basis of a Swedish registry, where 24% of the candidates to transplant could not receive the transplant. So it raised the question of the pre-graft therapy to know if this is benefit or not. Unfortunately, we don't have any prospective study randomizing the pre-graft treatment, so that could be a little bit provocative, but you can see that, for instance, in this single-center study, which compare upfront post-hypomethylating agent or post-intensive chemotherapy, the relapse-free survival is strictly similar. So the question of upfront transplantation in MDS patients without waiting for the response to a treatment is still a debate, but can reduce the failure to transplant. The second point is actually this chemotherapy or targeted therapy before transplantation. And we don't have prospective study, but we have a registry study. On the left, the French registry study showing no difference using intensive chemotherapy or hypomethylating agent in MDS. Only patients who received both in gray had a worse outcome. And on the right, at the EBMT study, showing that even if you have complete remission or not, that's not really important for the outcome. Which is important is that patients who are primary refractory have the worst outcome. And if we take all the studies using testing meta-analysis for pre-graft therapy in MDS patients, we fail to demonstrate a benefit of this pre-graft therapy. But we don't have all the information regarding new drug in development as well as combination, which may improve the rate of complete remission and maybe change or challenge this pre-graft therapy. And for example, see that the treatment of AML MDS patient with CPX 351, which give a very high rate of response. And in patients who have a donor, it can be used as a bridge to transplant. And you can see that the overall survival in transplanted patients is very good in these very high-risk patients. Now we'll see if we can improve the conditioning regimen to reduce the risk of relapse and if that's possible to intensify this regimen. So we have several phase 3 trials. The first one is the comparison between FB2 and WSI, and there is no difference in terms of overall survival. The second one is the American study, so it includes AML and MDS, and here I show you just the MDS subgroup. So that's different kind of MAC versus different kind of RIC. The overall survival at 18 months is similar using RIC and MAC, but there was an excess risk of relapse in the RIC group. So usually, the idea is to do a MAC when that's possible, meaning in fit and young patients. And the last study is the randomization between a RIC and a sequential conditioning regimen, FLAMSA. to reduce the risk of relapse. But unfortunately, this is a negative trial without any difference with the control. Recently, we have an update about the phase 3 randomized study comparing FB2 to fludarabine and triosulfan. And there is an advantage of triosulfan in MDS AML patients, mainly due to a reduced rate of NRM, but of course it should also be confirmed by other studies, but it can be an option in MDS patient to reduce NRM this time.
5 minutes remaining.
Yes. So I will speak about prevention, maintenance therapy to improve the post-transplant outcome, and it has been published with different combination or new therapy. All these new therapy gives a dropout around 50% due to infection, GVHD, or cytopenia. But when that's feasible, that's safe and it lowers the relapse risk. And at EBMT, there was the registry study comparing ESA to observation using a propensity score, showing an advantage of this maintenance therapy. Maintenance therapy with eprenetapopt may be very important in TP53 mutated AML and MDS patients. And here in this phase 2 study, we have very encouraging outcome in these patients. But unfortunately, the phase 3 trial comparing 5-ASA to observation was negative without any advantage in terms of relapse-free survival and incidence of relapse in the patient receiving low-dose 5-ASA maintenance. But there was again a lot of drop-off due to disease progression. So we should also think about the prophylactic donor infusion in MDS patients. And there are many ways to perform this donor lymphocyte infusion. The classic way is after immunosuppression withdrawn, but that can be an added back DLI after T-cell depletion, for instance, or manipulated cells. They are very encouraging results, but we don't have any prospective trial in this setting. And here, that's an EBMT abstract from the German group showing that using preventive DLI, the relapse risk is very low. So that can be an interesting strategy. And regarding preemptive strategies, that means that we follow CD34 monitor chimerism or some specific leukemic antigens, and we start the treatment as soon as this is positive. And in these two phase 2 trials, we can see that 88 to 100% of the patients can receive 5-ASA, and the response rate is around 80% in these cases. So maybe preemptive strategies are a very good option in the future. So to conclude, high-risk patients have a better outcome with transplantation. Pre-graft therapy with intensive chemotherapy and hypomethylating agent may limit progression to AML, but has not proven to be benefit in MDS patients. MAC is recommended when patients are fit and young, but you have shown that RIC give quite good results in these patients. Triosulfan may improve outcome as compared to besulfan, but should be confirmed in specific situation. Maintenance with 5-ASA has not proven its benefit in phase 3 trial, but more prospective trials are needed to, especially in specific categories of patients. So I thank you very much for your attention, and I would like also to thank all my colleagues from Paris University, to the French Society, and from EBMT. Thank you very much.